So the next speaker is Dr. Mallack, who's going to tell us about MRIs. Perfect transition.
All right, hello everybody. My name is Eric Mallack. I'm one of the child neurologists from Cornell. I also spent some time at Mass General, as Patty pointed out. Thank you for having me back, Florian. I appreciate the opportunity to give you an update on my work. So the title of the talk is Early Lesion Growth in Cerebral Adrenoleukodystrophy. And what we'll do is just talk quickly about the background of cerebral ALD, although it's been talked about over the course of this morning. But I'm going to take you sort of through three major projects that we've been working on, thinking about patients with asymptomatic childhood cerebral ALD, what the arrested cerebral ALD phenotype looks like, and then I'll give you an update on my volumetric analysis of early lesion growth. So, as you all know, cerebral ALD occurs in 50 to 60% of patients with ALD, majority in childhood, as Troy pointed out. It's defined by the appearance of a T2 lesion on MRI. It's been reported in the literature that 10 to 20% of patients never undergo contrast enhancement and they have spontaneous arrest of disease. And 80 to 90% of patients, unfortunately, undergo contrast enhancement, and that's the marker for bone marrow transplant for all the reasons of blood-brain barrier breakdown, etc. What is unknown, or at least not fully clear, at least from the literature to date, is how these paths diverge. As we know, there's a pre-symptomatic window, so if you transplant within the pre-symptomatic window, survivorship is excellent. We have newborn screening and G therapy, but there is the quintessential rub, that is, in the pre-symptomatic window for the patients with cerebral ALD, that it's been shown that some can undergo neurocognitive decline. Post-transplant survivorship decreases after onset of neurologic symptoms. We know it's fatal. And then Troy touched on the LESS score, the 1 to 34-point scoring system that tells you essentially what neuroanatomical areas on MRI are involved. 1 is low, 34 is high. And then there's been this clinical observation, which we all know, that patients with inflammatory cerebral ALD, their disease progression clinically speeds up over time. It accelerates. So clinical insight to keep in mind. So what's my interest? I'm interested in understanding what is happening in pre-symptomatic patients while the lesions are small. So this is starting to approximate the clinical scenario that'll be afforded to us by newborn screening. You identify the boy at birth, you do serial MRIs, hopefully capture the lesion before symptom onset, and then try to figure out who's going to do what, and then intervene, like I said, before symptom onset. So in biomarker work, oftentimes you have whatever you're looking at and you have to correlate it with a clinical outcome. So whatever the neurologic function score, or EDSS, or all these things that we're looking at. But in asymptomatic patients, we don't have a clinical marker. So as Bella Turk told me last night, this is where we apply math. And so that's what we did. So I'm interested, do patients with progressive cerebral ALD undergo disease acceleration prior to symptom onset? And I'm going to talk about what this means, but this is based on the clinical observation that the boys who have cerebral disease that have contrast enhancement, they get sicker faster over time. So I'm wondering, can I capture that in imaging prior to when they actually get sick? We're going to do that looking at quantitative MR, which in this case is lesion volumetrics. And this is part of an NIH grant I put in to work on this for the past 3 years. And my hypothesis was brain lesions in patients with progressive cerebral ALD follow a different growth trajectory than patients who undergo spontaneous arrest of disease, and we can capture that in the pre-symptomatic time period. To do this, we had to do really two things. We had to expand our understanding of the patients who undergo arrest of disease. What does that clinical phenotype really look like? There have been a couple case reports, and then there's a paper that everyone cites all the time with 3 boys that was published, I think, 10, 15 years ago. And then what does cerebral ALD look like in the pre-symptomatic time period? So I'll start with that. We, this past spring, published a paper in neurology looking at the MRI brain lesions in asymptomatic boys with ALD. And just some highlights. We found that of our cohort of 47, 60% of the boys presented with cerebral ALD. They were 7.1 years old, median age. Of the 28, 11 patients converted from a normal MRI in the study to childhood cerebral ALD, and they were a little younger. And of the 28 patients, 6 underwent spontaneous arrest of disease, and they were a little bit older. So we're starting to get sort of this age understanding of what brain lesions do based on age. And so this is just an example. Troy showed the LES score and showed what cerebral lesions look like in classical cerebral ALD. But in newborn screening, what we're really looking for are these tiny little white dots here, and this tiny little lesion here that grows slowly over time. You notice the time intervals between this tiny lesion here and there is 9 months. Normal MRI, tiny little lesion here. Over a year later it grows, and then over a year later it grows a little bit more. Same thing here. So these were examples put out into the literature to try to educate neurologists on what they should be looking for in early cerebral ALD. And here's a midsection cut through an MRI. You can see we're looking for these tiny little T2 hyperintensities. This is a coronal view through the internal capsule. Here's it on axial. And then what Troy was talking about a little earlier, we're looking for the patients that undergo blood-brain barrier breakdown. So what does blood-brain barrier breakdown look like when your lesion's not big? It looks like this little brush of contrast enhancement. So it's subtle. Oh, did I break it? I broke it. Okay, I didn't break it, good. So in this paper, we did a prelim volumetric analysis, essentially just looking at lesion volume and stratifying it over age, taking first and last scan. And what we found was, if you measure brain lesion growth and stratify it over age, you see this inverse relationship. Younger patients, their lesions continue to grow, whereas older patients, their velocity essentially goes to 0 as you get older. So it's a little bit of a different way to think about the disease. Moving on to those patients who underwent, those 6 patients that underwent arrest of disease where their velocity essentially went to 0. We wanted to expand the phenotype. So with collaboration from Mark Englund and Stephanie van der Staat, we put together a cohort of patients who have been diagnosed with arrested cerebral adrenoleukodystrophy and said, what does that patient population buried in cerebral ALD actually look like? And then what can it tell us about discrimination between the boys that we need to transplant and the people who we should not transplant? So we defined it as, and this was based on a consensus definition out of the literature, 2 or more clinical evaluations spanning a minimum of 6 months where on MRI, patients had no increase in LES score, there was no contrast enhancement, and no progression of cerebral signs or symptoms. So we were able to identify, so this is unpublished, but I'll give you a sneak peek, we were able to identify 22 patients. Cerebral ALD was first detected at 23 years old, so with a range of age between 8 and 67, which tells you that patients with quote-unquote arrested cerebral ALD were likely asymptomatic until they presented with AMN over time. But we have evidence of disease in childhood. And interestingly, in this population, the patients with arrested cerebral ALD, some of whom have AMN, they had scans that did undergo contrast enhancement, but it didn't have the same clinical outcome that we see in childhood cerebral ALD. You underwent a period of disease progression, and then the contrast enhancement went away. So it's sort of like the flicker that was being alluded to earlier. So this is just an example. This is the LES score versus time from diagnosis. The top graph here are the patients who never had any contrast enhancement on their scan. These are the arrested cerebral ALD patients. And you can see their LES score essentially stays. It essentially stays unchanged over time. And we have our farthest out data points like 17 years. There are the patients who had some form of contrast enhancement on their scan who were diagnosed with arrested cerebral ALD. And they may have had a bump in their LES score, but then they restabilized as well. And we have this for a neurologic function score. I can show you that later if you're interested. And so this is just an example. Here's a patient with a cerebral lesion, and then also has extension of demyelination into the internal capsule. And here's the T1 post-contrast, the T1 pre-contrast showing that on T1 without contrast being infused, there's this breakdown here, but then when you give contrast, you actually see blood-brain barrier breakdown in the brain. So demonstrating that patients with arrested cerebral ALD can undergo contrast enhancement, but their disease does not take off in the way that pure childhood cerebral ALD does. So To go back to the question of what I'm interested in, we've sort of defined the phenotypes: arrested cerebral ALD. How do they behave over time? What do the pre-symptomatic patients really look like? So what I did was I took those two populations, the boys with arrested cerebral ALD and progressive, and I measured their lesion volumes and effectively mapped them out over time. So the inclusion criteria for this part of the study: early cerebral ALD, defined as patients need to be clinically asymptomatic from a cerebral perspective, score less than 9, so early lesions. You needed 2 MRIs because it was a longitudinal study, and I limited it to colossal lesions only. What we found were 23 patients for this part of the study. There were almost 6, analyzed 101 MRIs, and on the first abnormal scan, the median score was 1. And then for the arrested cerebral ALD subgroup, same thing, a little bit older, median score was 3. So I have to stop here because last year I got in trouble because I showed graphs where things started going like this, really high, and I think I freaked a couple people out. Franny, I'm sorry. So if I did, I apologize. But I want to point out that we're dealing with small lesions here. I'm essentially just watching how they grow over time. So just a reminder. Okay, we're good. Okay. So how do we do it? So this is an MRI, multiple slices through the same brain. You can see the T2 hyperintensity here. This is a classic splenial lesion, a score of 2. Below it in blue is the segmentation of that lesion, so essentially highlighting it. And when you look at an MRI and you do it in multiple slices, you take these segmentations and then you essentially do some math. You can collapse them into a 3D space and then come up with a volume. And you do that for every MRI for every patient, and then when you map it out over age, this is what the data looks like. Now, to orient you, the patients in red here are the patients who underwent contrast enhancement and got bone marrow transplant or gene therapy. Over here, so these are all pre-treatment scans, and then over here are the patients in blue who underwent spontaneous arrest of disease and were diagnosed with that clinically. Okay, so we see a signal separation, I think, and that's kind of what we saw in the neurology paper that was published that I talked about just a little bit earlier. In thinking about children 0 to 18 years old, if we just focus in here, what we see is patients will tinker along. Volume of 0 is no lesion, no lesion, no lesion, no lesion. And then they'll come up with a volume that's non-zero. And what they'll do is they look like they accelerate over time. Again, small lesions. Scores of 1, 2, 3. Okay? But interestingly, what we aim to confirm is that patients who actually undergo arrest of cerebral ALD can also start in childhood. So there is overlap between these phenotypes, and we can see that. So if we take all of these growth trajectories and do a big cross-section and just look at velocities, and we just sort of map the velocities over time, this is what we see. And so this should look familiar. This should look like what we showed in the neurology paper, but with, instead of 28 data points, I think there's like 130 here. And what we see is the same inverse relationship. If we try to understand cerebral ALD as, and measure it with volumetric growth and then map that out over time, we understand that the older patients, at least the data supports that the older patients, their velocity goes to 0 over time, whereas if you're younger and you sprout a lesion, you'll probably grow. Now, granted, this is cross-sectional, this is not longitudinal. I'll do that in a second. If you take the second derivative, you get acceleration. So one of the features that you see in patients in the little boys with cerebral ALD that are going to undergo inflammatory conversion is that they do actually accelerate, which is not something you see in the arrested subgroup. So that's what's happening at the population level, but we want to know what's going on with the individual patient. So here's an example. 5 MRIs at 5 different times. Time 0 is here. Here's 10 months later. You can see I just blew up the cerebral lesion here so you can see it. It's this faint, subtle T2 hyperintensity here, 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 here. And it's a little more conspicuous here. So if you just list out what's listed clinically, time 0, like I said, 5, 6, 8, 10 months. What was it scored? Score of 1, 1, 1, 1, 2. Measure out the volumes, 0.5, 0.8, et cetera, et cetera. And then fold change over time, meaning if I take the volume at time 0.2, 5 months later, and divide it by 5.7, I get 44% increase. 0.86 cc's over 0.57, you get a 50% increase, etc. And then you can measure the rates. So you do this and you do some math and you put in a linear mixed effects model. I also threw it in a nonlinear one to see if I came up with a different answer. I didn't. And I'll show you that output in a second. But what this also shows is that early in cerebral ALD, what we demonstrate here is that the lesion's in fact growing, but the less score is not changing. So at least in early cerebral ALD, I think that the less score is insensitive to lesion growth. So this may be a more sensitive way of figuring out who may be getting sick. So this is the output, the data output. It's a little bit cumbersome, but I just want to orient you. I'll show you what all these numbers mean. But I want to show you here that if we do a linear mixed effects model and we break up the subtypes, arrested versus progressive cerebral ALD, what we find is the kids with progressive cerebral ALD, early on, for every 1 month, the lesion growth rate increases by 0.1 cc's per month. So that's not just the velocity, 0.1 cc's per month, but every month it increases. So it's 0.1 after month 1, 0.2 after month 2, 0.3 after month 3. That's the delta. So there's a degree of acceleration. Getting back to the clinical question was, can I capture acceleration early on radiographically? This is starting, hopefully, to be encouraging to show that the answer is, in fact, yes. Okay, and so if I do the fold change and essentially anchor everybody from the time of their first abnormal scan, the blue is the arrested patients who have arrested cerebral ALD. The red are the patients who continue to grow. In the progressive patients early on, while asymptomatic, lesion volume increases by a factor of 2.5 from baseline. And this is, if I just blow this area up right here, excuse me, here's 50 months out. That's not necessarily clinically useful, so if we're wondering what's going on in the first 12 months, we can see we get a nice signal separation here. It's like video games, got to blow into it. Let's see. Oh. All right. Your Apple ID is being used for something else. Okay. Allow, don't allow. Let's try this. It's not letting me advance. I'm getting boop. Yeah. Let's try this. Okay. So hopefully I've shown you a couple things relatively quickly, but that we see that disease progression when measured volumetrically is inversely correlated with age. Cerebral lesions in arrested cerebral ALD can actually, in fact, begin in childhood. In the progressive phenotype, I think one of the features that may be specific to the progressive patients is that they undergo early and sustained acceleration, whereas the arrested patients do not. And the less score is insensitive to early lesion progression. So what are the clinical implications? At the end of the day, I'm a physician, so I want to kind of bring this back to the patients and say, what can I tell you based on what your imaging is telling me? Patients with progressive cerebral ALD do in fact follow an accelerated disease course, which is part of the clinical insight that was handed to us by Hugo Moser. But that we can detect it early, and it can be captured, I think, in the pre-symptomatic window. And the nice piece about this is this technique is generalizable, so you don't really need any special sequencing. You just do T2 MRI, which is standard on all MRIs. Okay, so that's the research piece. And then one last thing I want to mention. I am in charge of with Dr. Turk the surveillance guidelines for MRI. Last year we alluded to doing a systematic review. We do have the surveillance guidelines, the expert opinion and consensus piece kind of done, but we're also supplementing it with a systematic review to give it data, to effectively make it data driven. And just a quick highlight on that, Dr. Turk and Helena, who's back there, they've been working tirelessly on the systematic review. We had 2 librarians help us, one from Hopkins and one from Cornell, came up with 12,000 articles between 1970 on ALD and up until September, I think, 12th or 13th. And we've managed to whittle it down to 159. Yes, 159. Both, and that's 2 independent scores. So hopefully we'll have some nice data to back up our recommendations and have that in for publication soon. So at the end of the day, what I've learned over the past 3 years, spending time with you guys in this community, is at the end of the day, this is about people and it's about family. And I've really been lucky to spend time with a family in Boston and then to build one in New York at Cornell as well. So I appreciate your time. Thank you. No questions, sweet. Okay.
So just to reiterate what you said, you think there might be a way of distinguishing the self-arrested lesions from the progressive lesions by looking at rate of lesion growth early in the course? Is that right? And can you add, coming back to you being a clinician, how would you gauge that? And age seems to play a role here as well, but just, yeah.
So yeah, this is a great question. So I'll talk about there's limitations in the data because it's retrospective for many of the arrested patients, we don't have disease onset. We just sort of have them when we pick them up, and that was through screening of siblings at that time. And I think clinically, we already kind of know what's going on. We're able to diagnose these patients by doing MRI in their late teens, early 20s, and we say, oh, you have a cerebral lesion. But I think, like you said, I think age is really the great discriminator. I think all I managed to do was quantify it and put some numbers to it to essentially show that I think understanding cerebral disease onset in relation to age is really important. However, there is overlap. So I think in terms of going forward, is this a potential tool for maybe discriminating in the 7, 8, 9-year-old who has a new lesion and we don't know what direction they're going? I think it could be helpful. You need prospective data or a bigger data set to kind of get disease onset. Which should come to fruition in the next 10 to 15 years. But I think this gives us at least an indication that that might be what's happening.
So I guess the scenario is a 9-year-old comes in with a gadolinium positive less score value of 2. Do you take him to transplant? Or do you wait? Yeah. And is there a cutoff in age where you wait?
I don't think so.
You don't think so?
Like I said, I think we inherently know this. Oh, sorry. Yeah. I can start talking. I think we inherently know this, and I think our practice is well done. But what I'm thinking about is newborn screening. When you have the 6-year-old who has a persistent lesion that, depending on your MRI cut, is it a little bigger, is it a little smaller, hasn't really contrast enhanced it, or maybe people haven't agreed on the contrast enhancement. Is there something that's happening in this less score of 1, 2 that can tell us maybe their trajectories differ a little bit? So as a research tool, I think it's helpful, but it definitely needs more data to fill it out. But a 9-year-old who comes in less score of 2 contrast enhancement, yeah, take them to transplant yesterday. Yeah. Yeah.
So I have a quick question here. Have you ever done like a retrospective study when you look at the outcome of the patients after bone marrow transplant and see if the better outcome is associated or correlates with this earlier acceleration? So in other words, if you can see early acceleration and kids perform worse after bone marrow transplant compared to the kids which will maybe, even without bone marrow transplant, arrest by themselves because they have low acceleration rate.
I don't think the data, there's not enough data there to sort of draw a threshold and say what the behavior looks like. You can kind of track it over time and get an idea. I'm trying to, does that answer your question? Like, I don't think there's a threshold, and there's not enough data here to give us an idea of rate of progression, time of transplant, who does better or worse. At the end of the day, all these patients, remember, are asymptomatic. And so these are the pre-symptomatic patients that went to transplant and did great afterwards. And I think that's probably the best we're going to do.
It'd be nice to see down the line.
Sure, what the post-transplant.
If you have AMN and
Yeah.
how it develops, and this is any correlation with this particular accelerated score.
Yeah, I think so.
Yeah. Thank you.
Do you have any data on integrating other sequences to this predictability? So we are just talking about the volume, and you're using T2. Have you incorporated the diffusion data, the perfusion data on these scans to see if we can do a multi-sequence prediction
Not yet,
analysis?
but we should do that.
Correct me if I'm wrong, but I was seeing the median age is like 7 for these lesions that you were talking about. Do you have anything on younger?
Yeah, so I didn't put the range in there. The range that we published was, I think the earliest one was like 5-ish, but there's publications in the literature that go all the way down to 3. Remember, time of diagnosis is sort of a loaded variable, because you can be diagnosed radiographically and you can have no symptoms, you can be diagnosed symptomatically. So you get kind of a hodgepodge. In this case, all the patients were asymptomatic, but the spread was, I think it got down to like 4 or 5
Okay.
years old. Yeah.
My son was 3 years old
Mhm.
when we discovered the lesion,
Mhm.
and of course he was not symptomatic,
Mhm.
as proactive as I thought I was, because his brother followed a similar course, but he ultimately passed away because he had a late diagnosis. So we were ready, to do everything. So he was 3 years old when he had an adrenal crisis, and he was in the Lorenzo's oil study and followed by Dr. Raymond at Kennedy Krieger, and he had asked for an MRI and also to have the adrenal function checked. The adrenal function came back that it was just a little bit, but they put him on, hydrocortisone anyway. The MRI was read, and they told us it was done at a local radiograph hospital in my area, and they said everything was fine, there's nothing there, and they sent a report to Kennedy Krieger saying he's fine. They did not send the radiographs. Back then it was radiograph. They didn't do the CDs. Because he was in the Lorenzo's oil study, I was called up because the doctor had to go to a conference, probably one of these, and could I come in earlier, because we were being followed every 6 months, because he was 2.5 when he went into the study. And I came down, and he did an MRI. And on the MRI, it showed that this was 2.5 months, 3 months, that there was a lesion there 3 months ago that was missed. And now it had tripled in size. And we
Yeah.
had to go to transplant. And luckily, Dr. Lund, responsible for doing transplant, and his team, and he's here today with complications. I don't hear a lot of younger kids like that. The protocol back then was, we will follow him, but really watch him when he's 4 years old. I mean, my son was 3 years old.
Yeah.
And luckily enough, I recognized what an adrenal crisis was, because his older brother had an adrenal crisis at 2.5 years old. And I'm assuming the lesion was there too. But he had no other symptoms till he was 5.
Right. Well, thank God for that. You figured it out early. I think this is the point behind doing the systematic review, actually looking at literature not only from the United States but around the world, to really get an idea of what we have. An idea of the age of incidence. It hasn't really moved. It's been repeated. But what is the real true age range that we should be looking at, and then how should we be monitoring these patients? But I know we're running out of time.
Thank you, Eric. So.